Hello and welcome to another deep dive clinical skills video. My name is Dr. James Gill and I'm one of the lecturers at Warwick Medical School, and today we're going to talk about the jugular venous pressure, or the JVP. So today we're going to look at what the JVP is, how to examine for the JVP, what conditions may produce a rise in the JVP, and what we can do with regard to the JVP in terms of its waveform and how to interpret that. Interpreting the JVP waveform is rather difficult. As a result, we're going to leave that till last, but hopefully it'll be the most high yield for you. So what is the JVP? The JVP is an indirect measure of pressure in the right atrium of the heart and the general venous system. The right internal jugular vein sits directly over the superior vena cava and the right atrium of the heart. As a result, any pressure changes in the right atrium will be transmitted up the column of fluid, or blood, that sits in the internal jugular vein. This means that we can use the internal jugular vein as a manometer for the right atrium and the venous system generally. The position of the JVP will tell us what the pressure is in the generalised system there. It's also where the phrase going for the jugular comes from, because if you were to sever both the internal and external jugular veins, which supply the entire flow of the blood from the head back to the body, well, that's going to be a killing blow, isn't it? One of the things that makes teaching the JVP in clinical skills such a challenge is that for most people, healthy people, the JVP is not visible between the sternocleidomastoid heads or above the clavicle. Yes, it can be up to 3 to 4 centimetres in height, so may just fractionally be visible, but in a lot of students it's not. Thus, if we come across a patient on the wards that has a raised JVP, then automatically we know that something is going on to increase the pressure in the right atrium or to increase the pressure in the venous system generally. And we need to work backwards to say, right, this patient has a raised JVP, what are the possible causes of that? And that may hopefully find us at the answer to what the patient's underlying diagnosis is. But before we delve into the minutiae of the medicine behind the JVP, we should look at how to properly examine for the jugular venous pulsation, because there are a few tricks to getting this examination right. So, when assessing for the JVP, we're looking for a visible pulsation in the right internal jugular vein. In a normal patient, we'd expect the height to be about 3 to 5 centimetres over the manubriosternal angle. But how do we actually do this measurement? Well, we have to have the patient lie back at 45 degrees on the couch and turn to face the left side. So if you just get you to lie back for me, and I'll just put the bed up at the same time. Okay. Super. So just having a look, if I could get you to turn your head towards the wall and just relax back for me. So I'm just going to move your t-shirt and having a look at the base of your neck here. Okay. This will allow us to get a good view of the patient's neck, but we need to relax the head as well. You can't do it with the patient sitting up, as their sternocleidomastoid muscles will be engaged, preventing you seeing the pulsation which will be between and or underneath those muscles. Hopefully we should be able to see a pulsation toward the base of the neck initially as the patient is lying there. If in doubt, there are 3 ways of confirming what you're looking at is actually the JVP. First, if you're concerned that you found the patient's carotid pulse rather than their JVP, have a close look at what it is that you're looking for. You'll see 2 subtle pulsations for every heartbeat on the JVP, whereas you're only going to get 1 pulse at the artery for every heartbeat. And you can confirm this by holding the patient's wrist to check their pulse whilst looking at the side of their neck. Although perhaps an easier way of determining whether or not you found the carotid pulse versus the JVP is to feel it. The JVP is said to be impalpable, whereas the carotid pulse will have a clear force against your fingers. However, the best way is to perform a special test called the Hepatojugular reflux. Quite often this gets labelled as the hepatojugular reflex. It's not, it's a reflux, as we'll show you now. So do you have any problems with your tummy at all?
No.
So what I'm going to do, I'm going to press on your tummy and see if I can see any changes in your neck. Is that okay?
Okay.
So if I get you to turn your head that way. I can't see any problems there. There's a slight pulsation right near the top of your clavicle there. So I'm going to press here on your tummy and see if we can get any movement there. Do you have any pain here?
No.
Okay, so it's going to press in. 1, 2, 3. Okay, and we've got a nice increase in the pulse, so that looks to be good. So you again get the patient to lie back at 45 degrees with their head turned to the left and relaxed, which will in turn relax the sternocleidomastoid muscles. Then we need to confirm that the patient doesn't have any abdominal issues. If the patient has no abdominal issues, we want to put some direct force over the right upper quadrant where the liver is. By pressing over the right upper quadrant where the liver is, we'll have increased blood flow from the inferior vena cava up the venous system. Thus, because we have a connected chain, we'll see that pressure go up the internal jugular vein, and we'll see a rise in the venous pulsation, or at least a rise by swelling in the neck. But I will highlight again, this is the hepatojugular reflux, not the reflex. So we've found our JVP now, and we've confirmed that it isn't the carotid pulse. How do we know if it is actually raised or not? You know, what's to say that this is a problem versus this is not? Because we can see the JVP in normal patients, don't forget. So we've found our JVP, but how do we know if it's raised or not? So we need to check on the patient's chest to find what's called the manubriosternal angle, also the angle of Louis. As the name suggests, this is where the patient's sternum and manubrium articulate against each other. Because don't forget, your chest is not one solid block, but you've got lots and lots of joints that allow your rib cage to move in and out. Having found this location, we put a 30cm ruler. I finally found a reason to have kept my pencil case from school. We put this ruler onto the patient's chest and then measure vertically upwards. We're just going to measure that to make sure that's the case. So just going to get the ruler. And I'm going to find the angle on your chest. So, and if we measure across, and that's easily 3 centimetres. So everything's looking healthy there. So the distance vertically of the JVP above the manubriosternal angle is the height of the JVP. Now normally the JVP will be below 3 centimetres in height. However, you might not be able to even find the JVP in a healthy individual because it's hidden behind the clavicle. Then we go back a full circle to confirm that the absence is because the JVP is below the clavicle by doing the hepatojugular reflux, which should make it visible once more. That is quite important because in some patients who are very unwell, the JVP can have risen so high that it's actually disappeared inside the skull. Thus, the hepatojugular reflux will have no effect on the position of the JVP. But if we look very closely at the patient, we may see the JVP causing their earlobe to waggle with each beat. So, if we have a raised JVP, what are going to be the causes here? Well, we can split these up by system. So cardiac causes would be right heart failure, right ventricular hypertrophy, constrictive pericarditis, cardiac tamponade, and tricuspid stenosis or regurgitation. Now, if we think about all of those, each is something which will have caused the pressures in the heart to increase. So, for example, if we've got right ventricular hypertrophy, we've got increased force that the atrium has to push against, pushing blood from the atrium into the ventricle. If we've got cardiac tamponade, then we've got less space for the heart to expand into, meaning we have increased pressure. If we have tricuspid stenosis or regurgitation, again the atria is having to work harder to overcome this, thus giving us a greater pressure, moving the JVP further up the neck. We may have respiratory causes, so that will be a pulmonary embolism, a blood clot in the lungs, or pulmonary hypertension. In both cases, the heart is coming across increased resistance in the lungs, having to push with greater force, thus we get a rise in the JVP. We can also have fluid overload as the cause of a raised JVP. Now this can be caused by myself, the doctor, or iatrogenic injury by giving too much fluid to a patient. It can also be due to renal failure or problems where the superior vena cava itself has become obstructed. However, there is a relatively simple mnemonic that we can use in order to remember the cardinal causes of a raised JVP. And that mnemonic is simply P, Q, R, S and T. So P having three issues, that being pericardial effusion, a pulmonary embolism and pulmonary hypertension in the chronic form. For Q, we have the quantity of fluid. We're kind of forcing it there, but essentially we're meaning that fluid overload we've talked about. R for right heart failure, and S for superior vena cava obstruction. And you're going to be able to see patients that have problems like that largely from the end of the bed because they've got obvious, visibly distended veins on the head and neck already. T for tricuspid regurgitation or tricuspid stenosis, and finally tamponade cardiac. We've forced it a little bit, but that PQRST should be a relatively easy way for people to be able to field answers on clinical ward rounds as to what may have caused that patient's JVP to rise. Now we compared the carotid pulse with that of the internal jugular vein, and we said that the JVP is actually more of a complex waveform because there's at least two peaks on the JVP that we need to be aware of. These waveforms on the JVP can actually tell us a lot about the body, much more than just our simple PQRST mnemonic is giving us. There are 5 sections of the JVP waveform, and we're going to go through those now. Now, we mentioned that the JVP has 2 pulsations to its waveform, and overall we could say that the JVP waveform is relatively complex. It certainly is when we look at it initially in the classroom. However, if we break it down into its component parts and understand why we are getting the waveform that we do as it's related to pressures in the heart, it'll actually become very clear. So there are 5 sections to the JVP waveform to pay attention to, but thankfully they've all got relatively easy labels. To begin with, we have an A wave, and this is responding to right atrium contraction, here as blood is pushed through the open tricuspid valve. Note that the valve is open for the A wave. We'll wind back to that in a minute. Hopefully we can see that for the atria to contract, if there is tricuspid stenosis, i.e. the valve at the outlet of the atria is thickened, the atria will have to exert more force in order to push the same amount of blood through that valve as it would do normally. Thus, if we have tricuspid stenosis, we'll get a rise in that first wave. Following the wave, we've obviously got the descent. This is the X descent and is where the atria is relaxing. Very important. As blood is flowing into the ventricle, the atrial pressure is further decreased. So we've actually got two factors causing this slope to decrease, which is why it's possibly a little bit more acute than the previous A rise up. Sometimes in the X wave, there's a barely perceptible C wave. The C wave is when the right ventricle first fractionally contracts, causing a shock wave to propagate back through the blood in the ventricle, causing the tricuspid valve to snap shut. This causes a brief blip of pressure in the right atrium, giving us our C wave. Realistically, we're not going to see that on a patient on the ward. However, it's something that internal monitoring will be able to pick up. So those 2 points make sense, but why does the X continue to go down after that? That's because of further contraction, not of the atria, but the ventricle. What we have to think here is that with that increased contraction of this massive part of the heart, we're actually getting even more space now available in the pericardial sac. Thus, there's less external pressure acting on the atrium, hence the continuation of the X descent. In many ways, we're looking at this from the opposite way round of pericarditis or cardiac tamponade, where there is an issue with the pressure on the sac causing increased forces on the heart wall, which would cause the JVP to increase. So hopefully you can see there how we're getting this interplay. After the X descent, we have a new wave going upwards. This is the V wave, and that occurs as the atria now starts to fill with blood, and that blood is coming into the atria against the closed tricuspid valve. Thus, the more blood going into the atria, the more the atria will swell, giving us our rise. But why, if we're getting a rise here as the valve is filling with fluid, why do we then get a dip down at the end of the Y before the next A wave? Because the tricuspid valve is open in the A wave and the atria will push against it. At the end of the Y wave, the valve is opening. So we have to have a brief decrease in pressure before the atria itself will begin to force it through considerably. Hopefully that makes sense. And with each pulsation of the heart, we'll rinse and repeat along that same pathway. So just to recap with that, the A wave is for atrial contraction, the X wave is for atrial relaxation, the C wave is for ventricular contraction, the V wave is right atria filling with blood, and the Y section is the opening of the tricuspid valve. Now obviously this is clinical medicine, so we're going to see other causes for a rise in the JVP beyond the previous P, Q, R, S and T mnemonic causes above. But those additional pathologies will all cause telltale abnormalities within the JVP waveform itself. So the A wave will increase if we've got right ventricular hypertrophy or tricuspid stenosis, as we mentioned. That's because the atria has less space in the pericardium because of the right ventricular hypertrophy, and it has to contract with greater strength against that tricuspid stenosis. Atrial fibrillation will cause a reduction or an absence of the A wave as the atria's contraction is disordered and we don't have a uniform change in pressure there. And that's pretty much all there is to the JVP. The main takeaway here today has to be that the JVP is due to raised pressures, and the commonest cause that you're likely to come across in the wards is heart failure. Don't forget, 90% of your diagnosis should be coming from your history, and thus you should be able to anticipate whether or not you're going to find a raised JVP on your patient even before you begin your clinical examination. I hope this has been a helpful overview of the JVP. If you've gotten some benefits, then please consider subscribing to the channel and you'll get a heads up when we do the next video. And personally, I'd be really grateful if you could give the video a like and possibly put a comment down below of any clinical scenarios or medical pearls that you're aware of. Perhaps we can all learn something together as a group. Okay, with that, I'll say thank you for watching so far. Have a good day. Take care. I'll see you on the next one.